Hi, good afternoon, everyone. Thanks for joining us today for today's session on the executive order. This is an update session on the proposed rules and the 60-day checklist. I still see some people signing in, so we're going to wait another 30 seconds or a minute here to get started, and then we will continue with today's session. All right, we're going to go ahead and get started with today's session. Just some brief introductions and a couple housekeeping items before we get started. My name is Brad Josephson. I'm the Director of Marketing here at PMMC. PMMC is a revenue cycle software provider. I've been with the company for 5 years, and with me today are two other people. Greg Kay has been with PMMC for over 20 years. He's the Senior Vice President of Revenue Strategy. And also joining us today is Tara Bogard, also a Vice President of Revenue Strategy. Tara has 18 years of experience working with hospitals on this very issue around price transparency and charge master rate setting. Just a couple of logistical items before we get started. We will take some questions at the end. This is a 30-minute session, so we do have a lot of material to cover. But if you'd like to ask a question, you can go ahead and enter it in the question tab in your GoToWebinar pane, and we will take it as long as we have time. And if we do not have time, we will be sure to follow up with a response after the session. So I'm going to go ahead and turn it over to Greg to get started.
Great, thanks, Brad. So as we all know, last year CMS followed through on the 2010 Affordable Care Act that required all hospitals to annually list their charges, including DRG groups. And at the time, most hospitals complied, but the information, as we know, with a lot of websites, have been hard to locate and really even more challenging to understand. As an example, many organizations posted just their CDM file with the charge description and the corresponding rate. On June 24th of this year, the President delivered an executive order titled Improving Pricing and Quality Transparency in American Healthcare to Put Patients First. Now, this executive order really focused on improving the patient's ability to more directly manage their healthcare resources, reduce barriers to pricing transparency, and really protect individuals from surprise medical bills. So in today's session, we're going to recap the baseline requirements, get into some of the specific components of the files that you're going to need to post online January 1st, and some key steps that you should be taking to move towards that effective date to post this information. It's really hard to believe that we're now only 61 days away from this particular executive order. It's just a level set. CMS has been very clear in the detailed regs that the intent of this mandate is to put the patient first, and that the requirement is for hospitals to help patients become more informed healthcare consumers. So as you're considering and working with your internal teams with what to do and how to do it, your team should be consistently asking, is the information that we're providing, one, easy to find, and two, easy to understand? Obviously, one thing for sure, our industry has not been accustomed to having to deal with executive orders directing us to do specific things, and those implications, as we're starting to see, can be wide-reaching and are likely going to be impacting multiple areas within your organization, starting with the revenue cycle area. So, Brad, I believe we're going to start today's session with a poll question.
Yeah, and as Greg mentioned, we are only 60 days out now, so we'd like to get an idea from the audience. How far along are you with your planning and preparation for the executive order mandate? So the question is, what has your organization done so far to prepare for the price transparency mandate? And the options with this poll question are that we've organized payer contracts for modeling, we've analyzed historical billing data for shoppable services, requested proposals for third-party vendor help, we've contracted with a third-party vendor to help, or we have not yet started preparing. So we'll give everybody about 30 seconds here to answer that question. I'll turn it back to Greg, and then we'll share the response here in just a minute.
Great, thanks, Brad. So beyond this being a federal mandate, it's also important for us to remember that most states have been taking steps over the last few years to make pricing more transparent and really to reduce the rate of healthcare growth. California started in the early 2000s, Massachusetts, Oregon followed suit. I think most hospitals have seen states that they operate in roll out similar pricing initiatives. So while the requirement to post gross charges are fairly new, it may seem like a new requirement with a very small window here with 61 days to go. But if you really look at the situation through the lens of the public, the legislation, CMS, our industry's been really slow to embrace this step of putting patients first with pricing transparency. It is our view at this point, and based upon the feedback that's noted here from the CMS hospital price team, it is their communication out that unless there are rule changes, the rules that are out there published to date will be effective January 1st. We may recall there was an FAQ that came out about the 12th of November last year that provided a few clarifications around what was going to be required with posting charges. We're hopeful that there will be an FAQ with some of the questions that obviously organizations like PMMC and others have provided. There will be some additional guidance with some of the details, but there is nothing that we've seen that would lead us to believe there's going to be a delay, if you will. So Brad, what are the results with today's poll question?
Yeah, we'll go ahead and share those results. So according to today's audience, about 32% have still not yet started preparing. That's definitely an improvement from our previous sessions. Another 31% have started analyzing historical billing data for those shoppable services. About a quarter of you have started organizing payer contracts. And then a small portion, 7%, have requested proposals, and another 7% have contracted with a third-party vendor. So I think it is encouraging to see that people are starting to prepare, but again, a third of us still haven't yet.
Okay, so as you're contemplating, is this really going to happen or not, and what do I need to do? It's important to consider the comments that CMS has received during the comment period that ended back on the 27th of September. At the end of the day, in our review of the comments, there was a significant positive response from consumers and advocacy groups for CMS to move forward with the mandate. In reviewing the comments associated with the 2020 outpatient regs, hospital opposition that we found primarily related to the 340B reductions, and many of the state healthcare associations and individual hospitals did express concerns about the effort and the resources needed to comply, and that the information may be more confusing than helpful. But we haven't seen anything that would really throw up a red flag, if you will, for CMS to put the brakes on moving forward with this particular initiative.
Yeah, and so while it might not be the ideal requirement of what to post, and we might believe it's going to be confusing information, and I think we all agree it's going to require a lot of work to do this, at the end of the day, consumers would rather have too much information versus little to no information, and that's what really this is all about. And like Greg said, based on our review of the comments, there really doesn't appear to be a compelling reason for CMS to delay this mandate in order to put the patient first.
So at this particular point, similar to the poll question earlier, our view is every hospital has a binary decision to make at this point. Is it going to happen or not? Are you going to be compliant or not? That's really kind of what it comes down to. I think many organizations that are still sitting on the fence hope the mandate will be delayed or overturned, but hope's not a plan, so let's look at some of the steps that you guys should be taking as we move forward.
Yeah, and we'll first look at who this impacts versus who it doesn't. So the current rules list those that must comply and those that are excluded. And the stated view with the federally owned locations is that these sites do not negotiate reimbursement, and there are nominal, if any, direct patient cost considerations. Most believe that it will be a matter of time before the current requirements are extended to AM surge centers and other healthcare locations.
So similar to CMS's guidance with additional data elements that'll be needed to go with the standard list of charges, CMS has also provided, compared to last year, some specific guidance with where and how this information is going to need to be made available. It can't be hidden or buried on your website, but it needs to be displayed prominently. They were very clear on that piece. It also needs to, it can't have various requirements to get data. There were some websites, CMS noted, that required usernames, passwords, login information, users to provide certain data. That will no longer be available. You need to make it easily accessible, and it needs to be easily found. So we've seen some organizations that had it 5, 6, 7, 8 clicks within to the client website. It's got to be far easier to get to, not directly on your home page, but you've got to make it easily accessible and easily found. So if you've decided you're going to meet the mandate, the next question is, what's required? So CMS's current rules outline 2 specific files that are going to need to be published. The first is your list of standard prices, or in other words, your CDM file with some updated information, and a list of shoppable services. So for planning purposes, we have estimated you take your time from last year to just post your CDM file. For every hour spent, you probably should plan on about 25 hours to go through your payer contracts, organize all the data, do all the calculations, to calculate the information out for these 2 specific files. Now, the second option is really to do nothing, which now, as compared to last year, does have some outlined penalties. If you are not compliant and you are reported, CMS will request your plan to be compliant. The current rules outline specific fines, and they have outlined a web page that will be created to list hospitals that made a conscious decision to hide their pricing. So as we start to think about our readiness checklist, the first thing, if you haven't started, is to be sure that you're organized with a specific team in place to start to look at your pricing transparency governance for your particular organization. This team probably is in place from last year. If not, a core group should include the CFO, patient access, who often receives the frontline customer questions, the managed care department, who has and manages all payer contracts and calculations, compliance, with this being a new regulation with specific fines and repercussions, and marketing from the standpoint of this is being laid out as a consumer-facing tool. So you want to make sure that you're communicating clearly and effectively, and obviously the back office for questions that are going to be coming up. The other piece is you should be monitoring CMS's website for updates and frequently asked question documents and their responses to questions that have been posed. The other piece to start to work through is really understanding and coming to a consensus with how your organization is going to create the two required baseline files. The open challenge is really going to be determining how you're going to calculate the negotiated charge, when, as we all know, reimbursement is typically defined with a payer at a claim level and not a CDM line level. So we've got to convert reimbursement data down to a CDM level negotiated charge. And we'll go into that in more detail in just a couple of moments. The other piece to look at and consider from a readiness checklist standpoint is looking at your current technology. Now's a good time to begin evaluating your current calculation tools, specifically contract management and your patient estimation tools. Going forward, automation is really going to be key. Now, when we think about increased pricing transparency, data from your CDM, your payer contract calculations, your patient estimates, and what's posted on your website should all be aligned. You will not be able to maintain those 4 different processes in an automated or a manual way in the future. Alignment and automation are really going to be critical because you're going to need consistency as pricing transparency becomes more the norm. As an example, some providers are already contemplating lowering some or even all charges, and these changes will need to be modeled through your actual payer contracts to really understand the net revenue impact. Percent of charge contracts, as we know, are easy to assess, but with outlier provisions such as lesser op terms or high outlier discounts are going to require a more detailed level of modeling than we've typically looked at in the past. Now, there was a recent article that was actually posted this past Friday on Becker's Healthcare Review related to several healthcare systems exploring the possibility and approaching CMS with decoupling the hospital charge master from Medicare payments. Now, this is being organized by, according to the article, HFMA and Levitt Partners, and it really speaks to the fact that outlier calculations with Medicare reimbursement today are charge-based, but what's being contemplated is possibly moving that to a cost-based approach, so as we adjust charges, we don't see negative impact to net revenue as we're responding to kind of a new norm in the marketplace, if you will. Your team should be reviewing, finally, your hospital website and really the page location for your pricing information. As I previously noted, CMS was very specific with accessibility to information and those proposed requirements. The other piece just to note, some organizations are starting to look at, as you're posting this new file, it's going to have anywhere from 40 to 200 payer plan code combinations and probably anywhere from 7,000 lines to 40,000 lines, incorporating some means that file, that document is searchable. So that would be something you're going to want to pull in your IT staff or whoever is maintaining your current website.
Yeah, and a few tips for communication and education, and this really comes down to being proactive. So really make sure that everyone involved with your organization, your board, your department leaders, and all your staff are aware of the pricing information that you're going to be posting publicly now. Make sure to utilize things like your internal newsletter as well. Be proactive with local media, and this is more a public relations aspect. Your marketing team has probably already met with them earlier this year, but don't wait for them to dig up pricing information and create a story. Make sure you're being proactive about that so you're not on your heels and having to react. And then finally, be proactive with your patients. This is intended to help your patients. So start with your website and include your frontline staff, and make this educational, and explain what these charges mean and how they can help patients better understand their cost.
Okay, so let's dig into the required data files and go a little deeper here. So for the upcoming mandate, CMS has provided additional guidance in putting the patient first by making data that we're posting more useful and comparable. Additional required items for your CDM file that they have specified include the code and the description. The description is what a lot of hospitals were previously listing along with just the gross charge. But we're now also going to have to list the corresponding HCPCS or CPT code, the corresponding revenue code, and other relevant information such as the NDC code, or in this particular example, the modifier as well. For multi-facility organizations, the charge information should be at a facility level, whether you're listing all facilities in one file or having separate hyperlinks to each specific location. It's going to need to be facility specific. And as previously noted, CMS has expanded that definition of charge with the new mandate to now mean both gross charge and the negotiated charge for all contracted payers and plans. Now, this particular example on screen highlights how your current posted CDM file is going to need to be expanded to include these additional data elements, plus the negotiated charge for all contracted payers and plans. It's important to note that CMS did outline for Medicare and Medicaid, since those are not negotiated contracts, they do not need to be listed per se, but obviously if you've got Medicare Advantage and Medicaid Advantage, you're going to need to calculate those values to be able to list out on your website. Now, the negotiated charge is a new concept. Obviously, years ago, payers and providers negotiated discounts from charges. So those contracts that are percent of charge should be fairly easy to calculate and list. But for those contractual payer arrangements that really are prospective payment, the process is going to be more challenging. One option that I've heard and have seen, I don't necessarily agree with, but it's one option that one organization has contemplated, and that's to not list anything or to insert an NA as the reimbursement is not negotiated with their payer at a charge code level. Now, that might be okay to meet the initial mandate, but it really isn't following the intent of providing useful information. Now, another option is to apply an overall effective contractual discount rate across your CDM. Now, this is going to be an easier approach, but it may lead to large rate discrepancies when there are fee schedules with significantly higher discount rates than the overall effective discount rate of that particular contract. Now, another option in doing your calculation, and the one that we really recommend, is to utilize and map the corresponding CPT to the charge line fee schedule rate, and then allocate the reimbursement from the revenue codes down to the applicable MAP charge codes, and apply the all other percent of charge discount to the remaining item. A key recommendation here is to really determine a methodology and apply it consistently across all payers and plans. As we know, problems typically arise from the exception and not the general rule. So if we can explain the rules, you've got something that's defendable. Exceptions that are not easily defined really make them a challenge to defend. Now, the second thing that we're going to look at is the requirement around the shoppable file, and CMS defines it as a service package that can be scheduled in advance. And to create this file, The first step is really going to be to analyze your billing data to determine an ideal claim or patient scenario for everything you do. And then based on those services, which shoppable items are you going to post? Now, CMS has provided a list of 70, and each hospital organization, through your governance team, is going to need to determine which other services, 230 other services, are you going to be posting as those shoppable items. Okay. So CMS provided, like I say, a lot of detail around what should be included with both the gross charge, the negotiated charge for every payer and plan. Similar information outlining what should be included, if you will, through the particular process. Now, to meet this particular shoppable file, this example on screen begins to show you how the data may be presented. This particular example has two hospitals, Hospital A and Hospital B. And in the first couple of lines with the service line CPT code 95810, we can see that particular claim has one charge line level, and we list the gross charge and then the negotiated charge or rate, if you will, for all payers and plans. Where it becomes a little bit more complicated is when you look at the next line down, the service code 80048. We've got multiple codes, in this particular case, 3 charge codes that roll up to a claim. So we've got to calculate both our gross charge and then allocate down the detailed charge from that claim level across all payers based upon the negotiated rate that we have in place. Again, if all of our reimbursement was percent of charge, this would probably take the 12 hours that CMS had originally outlined this particular project taking. Obviously, most organizations have significantly higher prospective payment, so that's where the real challenge and resource time is going to come into play. As you're going through the process, as I mentioned earlier, CMS has provided a list of 70 items. Some of these items are single line, others have multiple lines. There is a combination of outpatient and inpatient services. There are 5 DRG codes that they have on the list of 70, so you're going to need to do the reimbursement calculation for everything.
Yeah, and so we outlined a lot of tactical steps and tasks that you should be thinking about in order to meet the mandate and be compliant. But I think it's really important not to lose sight of the bigger picture here, and that going forward with price transparency, we really have to be willing to adapt, and we have to think about being strategic and really start thinking about how are we providing information for our patients to better understand the cost of care, because that's really the goal in all this moving forward, and that's really where our industry is going.
So it's important as you're looking at kind of the silos of organizations that leverage an accurate allowable, we're going to need to really take this process to a different level as we go forward, where the accurate allowable really gets leveraged in these 4 components as we go forward. Now, to both meet the mandate, you're going to need to create those files and have that information available on your website. If you do need consulting support, PMMC is available to help generate and provide the data that you need to meet that particular mandate. We also provide ongoing services where we are going to be analyzing market data and then comparing what our clients have posted to the competitors' rates so that you can do ongoing analysis and updates to the process. And obviously, where CMS is headed with all of this, and our industry has said this is where we need to be, that's really deploying a self-service patient out-of-pocket estimation tool. The industry needs to embrace that part. As you're working with your internal teams, your pricing transparency governance team, you need to go ahead and put on the agenda the selection of a self-service patient estimation tool. That will likely be the mandate that we're going to be seeing come to fruition. and it's probably going to be what we're talking about this time next year because the industry, I think everyone recognizes that that's a key missing component to all of this today. So in terms of closing thoughts, what we've outlined today are really very tactical steps and tasks that you need to do to be compliant with the mandate that we believe is really going to be here January 1. But to really win going forward with pricing transparency, you're going to have to adapt. You're going to have to be more strategic. You're going to have a plan that you can work and are willing to update as you go forward. What we're recommending is a whiteboard session that starts with really defining pricing transparency for your organization. And then all departments should be aligning to that particular definition from the executive team down. Once you have that definition, really identifying what are the outcomes you want, how do you then map and identify current processes that will get you there, where there are gaps that lead to KPIs that will really support those defined goals and objectives. This particular whiteboard session is complimentary if there are any clients that are interested in that as you go forward and are working with your team. So to wrap things up, I think we may have a few questions and we'll switch over to those. What do you think, Brad?
Yeah, I think that sounds good. I know we're up on 30 minutes, but we'll stay a few minutes past to take any questions that have come in. So one question we had is, will we be sending out a copy of the slide presentation? We will, shortly following the session. And we've recorded the session today, and that will be available by tomorrow as well.
So as Brad's going through some of the other questions, one that came up earlier today on the conversation with a client was whether the requirement was for just outpatient services, since it was tied to the 2020 outpatient regs. CMS in several different locations of the regs themselves referenced DRGs and DRG calculations. So it is for all services. So do keep that in mind. It is not for outpatient only. The next question is, where do we get the list of 70 codes? As a follow-up to this particular call, Brad can forward that Excel spreadsheet list out. It's in the reg. I believe it's page 348 of the reg, but we've downloaded it into an Excel spreadsheet. So we'll send it out to everyone just so you'll have it easily available.
Another question that just came in, how do you post negotiated prices when it's paid by APR DRG?
Yeah, great question. It's going to be the same thing for really any inpatient service or outpatient service that's paid under a prospective payment. You're going to have to go through and determine your methodology. CMS in the current reg did not provide guidance with specifically how to do this. As I mentioned earlier, one way is to look at what's the overall effective discount rate with the contract, and you can allocate it down to the detailed charge code level. A more accurate way would be to look at what charge codes are tied to what revenue codes, allocate your reimbursement down to the revenue code level, and then on down to the charge code level. The same thing that would apply for your procedure codes, your HCPCS codes. All other services would be calculated at an all other rate. But you're going to have to go through a process and determine a methodology, if you will, of how you're going to allocate claim level reimbursement down to a detailed charge code level. We've got a specific plan that we've put together that we believe meets CMS's intent. And if anyone is interested in understanding more how we're going about doing that, we'd be glad to arrange a call.
And we'll see if we have any more questions coming through here.
So one of the questions was for the 4 alignments with automation, what components do those tie to? It ties to your contract modeling, how you're modeling contracts on the front end, the audit process, your strategic pricing methodology, how you're setting charges and then calculating through and understanding the net revenue impact. And then that should tie into your patient estimation process as well. So the next question was, is it noted for the impact screen? It said acute care sole community. What was the one after inpatient rehab facility? Oh, I'm sorry. We'll go back and send the PowerPoint slide deck out to the group if you're referencing that particular slide, just so you'll have the information. The next question, how will this be enforced? So CMS has put in place some processes as it relates to advocacy groups, consumers, individuals, reporting up to CMS that they cannot find the information that is being mandated. So it's not necessarily going to be self-reporting, but it will be the market, if you will. CMS does have a specific pricing transparency team. I would imagine at some point that team will be looking at some of the compliance components, but initially they will be probably taking market feedback with which hospitals have not posted the information. And to be real clear, there are advocacy groups out across the country that are very much in favor of this, and I'm sure those will be the organizations that will be sort of the feet and hands of what CMS is rolling out here, because they're looking for, again, consumers to be more in control of the process as we go forward. The next question is the fine reduced if you don't meet all the requirements? That's going to be up to CMS. What they've outlined is the fine is $300 per day. They will first, if you are not in compliant, they will first request what your plan is. And then, you know, if you've got a plan that meets some but not all, CMS may waive the fine, or they may be a partial fine. They didn't go into a lot of detail with what the fine reductions would be. They just noted what the max would be, and that's $300 per day. The next is, what's the threshold for including a payer? Is it dollar or volume? According to the reg, it is all negotiated, contracted payer organizations. So if you've got a contract with a payer, you will need to list them as a part of your 2 files, both the shoppable file and the CDM file. There's not currently a threshold, if you will, where you don't have to list it for some of the smaller volume payers. The next question was, with the Becker's article, could you send a link? We'll be happy to send that out as a follow-up to this. Another question was, does this apply for all hospitals or ones with a specific number of beds? It does apply for all non-government owned hospitals, would probably be the easiest way of describing it. Any hospital that negotiates payer contracts would be another way of looking at this. VA hospitals, Indian reservation facilities were excluded specifically because, in their view, they were not negotiating with payers. Those were the only exceptions. So one of the next questions is, for Medicare Advantage plans that pay as a percentage of Medicare DRGs, they're not simple calculations due to the wage index, DISH, et cetera. How should we approach this DRG calculation? Really, with any prospective payment, you're going to have to, in our view, identify ideal cases or ideal claims for all the services that you do. And then you're going to have to calculate out the expected reimbursement with that ideal case, and then come up with a allocation logic to convert and move from a claim level down to an individual charge code level, the corresponding gross charge that you're going to have on that particular claim, along with the negotiated charge. Since you will have listed in your CDM now the corresponding rev code, CPT, HCPC code, etc., you should be able to allocate that value down. There was another question, will there be a repeat of this webinar for anyone that missed it or just emailing the PowerPoint? We will be posting this particular webinar up on our website and can send out a link if it is something you want to share with others. We are scheduled for a follow-up webinar coming up in mid-November in anticipation of an FAQ coming out that will be covering some of the changes, some of the clarifications that CMS has provided, and more information will be forthcoming with that. The next question is, can PMMC do this for other organizations? Yes, for clients that are current clients, we do have all of their historical billing data and the payer contracts typically loaded in our system. Those clients, we will definitely be able to hit the deadline for the January 1st mandate. For those clients that are new clients, we do have some recommended steps, and there are ways that we can work with the organization to both meet the mandate and become more fully compliant over a couple of weeks, few weeks after that.
Great, and I think that's all the time we have for questions. I know we didn't get to everybody, but we will follow up with responses to all the questions from today. And I will be following up shortly with a copy of the presentation and a recording link from today's session. I'll also include a link to my calendar if anybody would like to schedule 30 minutes with us to talk about this further. And I'd like to thank Greg, and I'd like to thank everyone for attending today.
Yeah, and just a quick piece on Brad's list. We'll also be sending out the list for the Beckers, the hyperlink for the Beckers article, and we'll also be sending out the list of 70 shoppable items. So you'll be receiving a couple of emails from us here this afternoon. Great, thanks again, Brad. Do appreciate everyone's attendance.
Thanks, everyone.